My name is Kelly. I'm with Aeromed. You guys probably know Ari in the back. She's with Aeromed also. I'm a flight medic with Aeromed. Ari is our outreach coordinator. Ari flies as well as doing the outreach stuff, and I fly full-time. My side gig is I'm also a respiratory therapist. So I've flown at Aeromed for 13 years, and I've been a respiratory therapist for 10 years, and work actively with both. So I still, basically do respiratory therapy at least one shift a week, if not more. So usually, then we fly 2 days a week. So point being is that I'm active with both of them. I've been doing both of them for a pretty good while, so I have a good grip on stuff. But my whole purpose, and I talked with some of you earlier about this, but my purpose isn't to make you guys respiratory therapists. And I get it that we're not going to prepare you with the same amount of knowledge that you would get in 2 years worth of schooling. But my point and my goal in doing this lecture for you guys is to give you guys some good knowledge, have a good foundation, and based on your patient's clinical presentation, to be able to make some good decisions for things that you might be able to do better for them for the vent, to make sure that they oxygenate and make sure that they ventilate. Because that's what it boils down to. When you have a patient on a ventilator, those are the things you're worried about. So just some objectives so that we know where we're going. We're going to talk about some terms related to ventilator functions, modes. We're going to talk about some parameters so you guys have a good idea of some jumping points of where to go with some of these settings with the ventilators. Also want to increase you guys' understandings of different ventilator modes and the decision processes maybe to take into account. And like I said, basically just the clinical presentation of the patient. And we all know that, we could transport 10 intubated patients a shift, and all 10 of those are going to be different because there's going to be different clinical presentations to all of them, or something that'll be slightly different. We're going to talk quickly about assessing ABGs. The last lecture we gave, I talked to the guys in the class, and it sounded like you guys did some interfacility transport from time to time, not a lot, but on occasion. So I wanted to give you guys just a quick tool to help you assess ABGs so that'll help you in deciding if you need to make some ventilator changes as well. And then also just some troubleshooting stuff, specifically troubleshooting stuff with the ReVel. Some things you can do, especially with settings, that can help alleviate some of the alarms, as we talked about, the typical electronic equipment, and a lot of our tools that we use love to beep and alarm. So anything we can do to mitigate that is for the better in my eyes. So some topics of discussion we're going to talk about, like I said, terms, ventilator modes, settings and parameters for the vent, some troubleshooting, the rapid ABG interpretation, some pointers for the ReVel, like I said, clinical considerations. And we're also going to talk about 2 case studies, and we'll get to those in just a minute, but we'll briefly talk about them at the front end of this lecture. And then after we get through the lecture, then hopefully you guys will have some more knowledge, and at the end of the lecture you'll be able to see what's wrong with the clinical picture on both of the case studies. So that being said, this is the first case study. This is a 68-year-old male, is 80 kilos. We'll say for sake of discussion that that's his ideal body weight as well. He's orally intubated with an 8.0 at 23. He's sedated, he's got a GCS of 3, and is being ventilated on your ventilator. His current mode is SIMV. His settings are a rate of 10, tidal volume of 550, FiO2 is 100%, and his PEEP is plus 15. His vitals, as you currently see on your monitor, is a pulse of 62, blood pressure of 84/64, total measured respirations of 10, and a SAT of 98%. So like I said, there should be a couple of things that jump out in that scenario. Don't say them now, and if you don't know, that's totally fine. You will by the end of the lecture. And next one, case study number 2, 38-year-old female, 65 kilos, intubated with a 7.5 at 21, presents alert, supine, restless. The peak pressure and respiratory alarms are going off on your ReVel as usual. And the mode you're in currently is SIMV PRVC. Your respiratory rate is 24, tidal volume is 750, and FiO2 is 60%, and you're at +5 for your PEEP. Current vitals you see on your monitor is pulse of 60, blood pressure of 102/72, a total measured respiratory rate of 42, and SAT of 98%. And also you see on your ReVel peak pressure being measured at 54. So there should be, again, on that slide as well, a couple of things that jump out at you that you should want to fix. But like I said, don't say it now, and we'll go back to these at the end of the lecture. So just keep all that in your mind, and that's our jumping point. So we're going to start from there and trudge on forward. So we talked a little bit about this earlier, but basically why to use ventilators. I would say the biggest two things on here is, in all reality, it frees up your hands. And more importantly, and I listed this as the first item on here because I think it's probably the biggest argument for vents, is it delivers consistent pressures, consistent volumes, all at a consistent rate. And like I said earlier, I'm sure all of us in this room can use a BVM like a champ. And I'm sure we've all done it many, many years and feel very, very comfortable with that. But at the end of the day, even bagging somebody with years of experience, you're still not going to be able to deliver the consistent pressures, the consistent volume, and the consistent rate that a ventilator can do. Other reasons to use ventilators is it prevents barotrauma from bagging, which obviously matters. Another reason is optimizing CO2 and O2. As I mentioned a minute ago, that's the name of the game for when you're talking about ventilation and patients being intubated and managing them effectively is, are they oxygenating and are they ventilating? So those are two big things you want to keep in the back of your mind as we move forward through the lecture is, are they ventilating and are they oxygenating? Another reason for vents is preventing alveolar shearing, which what that is basically is the alveoli, which are the little balloons in your lungs. If those expand too rapidly, especially if they're pretty brittle, like take like an ARDS patient, if you rapidly inflate those, you can rupture them, and basically that's called shearing. And so with the shearing, obviously, then now you lose the function of that particular alveolar sac, and a lot of that's kind of a cascading effect, especially with things you talk about with alveoli. So you shear one and it's a cascading effect, and obviously then again, you're not ventilating and oxygenating as effectively as you could. So something to prevent, something that could be significant. Also offering multiple modes to use for the ventilator as opposed to just doing assist control. You have a lot of different modes, and we'll talk about those and maybe which modes might be best for your particular patient. So some terms that are kind of some general terms that we'll talk about a lot in this lecture. Tidal volume, which is, you see the abbreviation is a capital V small t, which is a volume of air that's inhaled and exhaled from the lungs during patients' either respirations or ventilation. So basically, it's the breath that you take each time you breathe. That's obviously measured on the vent, and also you can set that as one of the parameters. Another item on here you'll hear a lot in this discussion is PEEP, which is PEEP, also known as positive end expiratory pressure. I'm sure everybody in this room is familiar with that. Basically the application and maintenance of pressure above atmospheric pressure. And basically it's throughout the expiratory phase of positive pressure ventilation. And I'll put a little note in here in parentheses, your intrinsic PEEP, in other words, your normal PEEP when you're breathing through negative pressure, like we are all doing right now, your intrinsic PEEP is 3 to 5. And so that's your normal physiologic PEEP basically. So that's why we typically have our PEEP setting at 5 when we're doing it on the ventilator. The next one on here is peak. And a lot of people can get PEEP and peak messed up or get them mixed up because they sound very similar. So peak is peak inspiratory pressure. And so this is a big, big thing that I that we'll talk about quite a bit in this lecture. And probably one of the big takeaways from this lecture is knowing what your peak or your peak inspiratory pressure is, and knowing how to trend that and what that means. And we'll get into that a little bit further in the lecture. But if there's any of these terms I would emphasize the most, it would be this peak inspiratory pressure. So the thing to know about peak inspiratory pressure is it's the highest pressure achieved during inspiration on positive pressure ventilation. Your tidal volume is a big contributor to your peak inspiratory pressure. In other words, the higher the tidal volume, the higher that your peak inspiratory pressure can be. So keep that in the back of your head as well as we move forward. Another term on here is plat pressure. A lot of times this is referred to as plat. It's a measurement taken during positive pressure ventilation, and basically what you need to know about it is it's a static measurement. So the plat pressure is taken when no flow is being delivered, versus peak inspiratory pressure, which is a dynamic pressure, a dynamic measurement. Peak inspiratory pressure is taken while flow is being delivered, and the plat pressure is taken when there's no flow being delivered. So just keep that in mind. Another term on here, as you see moving on, is minute ventilation, abbreviated VE. So minute ventilation is the amount of gas inhaled and exhaled. Basically, it's their tidal volume all added up within a 1 minute time span. The target, or what is quote unquote normal for minute ventilation, is 4 to 8 liters a minute. And that should ring a bell for you because that's also your normal for cardiac output. So if that's something easy for you to remember, is just think about 4 to 8 liters a minute. And why that matters is you'll see as we get through this lecture, you need to be able to set your tidal volume and make sure that your patient is reaching somewhere in that range. So just keep that in mind, 4 to 8 liters a minute. So ventilation types, basically you have two choices. There's two categories. There's invasive and non-invasive. And then ventilation delivery, basically you have two types of delivery. You have either a pressure ventilation or a volume ventilation. It's basically one of those two. Out of all the different vent modes that you have, those are your two choices. You either have pressure ventilation or volume ventilation. And we'll get a little bit more specific into that. Basically, with talking about some more terms and how it ties into the previous slide, non-invasive ventilation, as you guys probably are familiar, this is where with your CPAP patients and BiPAP patients, and it is basically the big takeaway with that is non-invasive is without an artificial airway, and invasive ventilation, as you see the next one there, is with an artificial airway, i.e. like a ET tube or a trach. So basically moving on with pressure ventilation, as we talked about earlier, one of your two choices of where you can go with ventilators. With pressure ventilation, you have a constant pressure and a variable volume. And with volume ventilation, you have a constant volume and a variable pressure. So basically kind of think of it as a seesaw, one on each end. And so it's kind of an inverse relationship between the two. But just basically know that if you're in pressure ventilation, your pressure is what's going to be your constant. And if you're in volume ventilation, your volume is what's going to be your constant. Last one on the list here is pressure support. And basically what pressure support is when you have patients in SIMV, it helps augment their spontaneous effort. And so basically another word for pressure support is tube compensation. So it's helping the patient overcome breathing through the ET tube and through the circuit. So it's giving them a little bit of extra pressure to help them overcome those adjuncts and help overcome a little bit of resistance. Another term for you here is auto PEEP. You may hear that talked about throughout your careers, and especially with ventilated patients. And we'll talk about that more in depth, but basically it's a buildup of pressure. And the reason you have that buildup is because the patient doesn't have a chance to completely complete their exhalation phase. So you have this buildup of air. And the other reason you could have auto PEEP is for an airway obstruction. And then finally here, inspiratory hold. It's the maneuver that you do to obtain your plat pressure. Because as I said, your plat pressure is a static measurement. So you hold volume or air being delivered to the patient to get that measurement, and the maneuver that you do to get that is called inspiratory hold. And you can do that on the ReVel as well. So we're going to talk a little bit about IE ratio, and because we're going to talk about that a little bit further in this lecture as well. So IE ratio is basically the ratio between inspiratory time and expiratory time. So how you figure that is you start out with your total cycle time. So your total cycle time, how you figure that is you have 60 seconds in a minute, which is where we get the 60 on the slide, and you divide that by your rate. So in this example, we're saying that the patient's respiratory rate is 10. So you take 60 divided by 10, so that gives you 6. So 6 is your total cycle time. The other constant you have with that is your I time, which is your inspiratory time, which basically is always 1, and 1 meaning 1 second. So you take 1 minus your 6, and that leaves you 5. So basically you have 1 as your inspiratory time, and the 5 that you get is your expiratory time. So what that means is 1 second for inspiration, 5 seconds for exhalation. So now your IE ratio is 1 to 5. So that's what IE ratio means. That's how you figure it, and we'll talk about how that's relevant. But as you can see from this example, the faster the patient's respirations are, like if you substitute 10 for 20 or 30, then you can see how that's going to affect your E time, because that means your E time is going to be shorter. And that means your IE ratio is going to be tighter. It's going to be more like a 1 to 1 or 1 to 2 versus a 1 to 5. And we'll talk about why that matters in a couple minutes. The next thing to figure real quick on here, another calculation, is ideal body weight. As I said earlier in the 2 case studies, the ideal body weight, why that matters is because that's how you're figuring the patient's tidal volume. And we'll talk about what the parameters are for that when we get to our parameters slide in a minute. But basically that's how you figure your ideal body weight, is you take 106 plus 6 times the value in your parentheses. You see in the parentheses it's a capital H. That capital H stands for height, and that's the patient's height in inches. So you take their height in inches minus 60, you get that value in parentheses and multiply it times 6, add it to 106, and that's the patient's ideal body weight. And that's for adults. So ventilation modes, as I mentioned, you either have 2 roads you can go down of either pressure or volume. And there's more pressure modes, as you can see from this list, than there are volume modes. So pressure modes, basically you have pressure support, you have pressure control, you have pressure regulated volume control, which is a lot of times just referred to as PRVC. I use that mode very, very often. Also, you have synchronized intermittent mechanical ventilation, which is commonly referred to as SIMV. I use that mode very, very often also. And then last on the pressure list is airway pressure release ventilation, which is known as APRV. The reason I threw this one in the slide is because you're not going to see that a lot in the transport environment, but you will see it potentially in your interfacility transport environment. Patients that are on APRV don't have a ventilation problem, they have an oxygen problem. And so typically the patients that are on APRV are going to be typically like your ARDS patients. And so just I wanted to at least touch base on that so you guys were familiar, or at least had heard of it if you happen to come across that in your daily task of doing interfacilities and so forth. As you can see on your volume mode, it's quite a bit shorter of a list. You have volume control, assist control, which is, I put that a slash right there because it's basically the same thing. The reason you have different modes or different names for different modes is because ventilator companies like to come up with proprietary names for their ventilators that, you know, makes their ventilator something new, something different, when in fact a lot of times it's the same mode as another ventilator. They do that, I think, to as a marketing tool to try and sell it, and also to confuse us. So, and then of course volume support is your other mode for volume modes. So we'll get specifically now into different ventilator modes and kind of the nuts and bolts of all of that. First one on our list we're going to talk about here is, like I said, assist control and volume control, which is the same thing. With that mode, the ventilator sets the rate, or obviously the ventilator sets / you set the rate, you set the tidal volume, and you set your level of PEEP. The patient can take a spontaneous breath in this mode, but if they do take a spontaneous breath, they're going to get the tidal volume that you set. So in other words, if you have them set on 500 or 550 for a tidal volume, if they take a spontaneous breath, that's the breath they're going to get, is 500 or 550, whatever you're set at. So, and we'll talk a little bit about that here in a minute, but patients you typically will see that are in this mode is patients with a normal respiratory drive, or excuse me, patients that have a respiratory drive but have weak respiratory muscles, like a diaphragm complication or a neurogenic issue, or in this case, two examples of myasthenia gravis or Guillain-Barré. Those are typically patients you would see that on a lot. The complication of this mode is respiratory alkalosis, because you can blow off a lot more CO2 than you're really wanting to. So the good, bad, and the ugly about assist control. The good thing about it is if you have a patient that's sedated or that is paralyzed, then you're going to make sure that they still get their volumes. And like I said, it's going to be a consistent volume, so you'll be able to easily meet your minute ventilation target. And it's good, like I said, for neurogenic dysfunction patients, i.e. their Guillain-Barré, and giving the specific required volumes will all be done by the ventilator. So if the patient doesn't have any extra effort on their own, that's fine, because they're still going to get their volumes. The bad about this mode is, like I said a minute ago, if they take a spontaneous breath, they're going to get whatever the tidal volume you set. So if you have it set at 500, every spontaneous breath that they take, they're getting 500 mLs of tidal volume. So that may be more than they want. It may be more than they need. The problem with that is that now, as we get to the ugly of this, that you can lead to air trapping, because you have a lot of excess volume that's being delivered. And along with air trapping comes high peak inspiratory pressure that we talked about earlier, and also decreased cardiac output. So if you have a patient, basically to summarize this slide, if you have a patient that's breathing over the vent, and they're breathing over the vent a lot, like I'm talking 10, 15, 20 times plus over your set rate, assist control isn't the mode for them, because you're going to have a lot of excess volume, and it's going to be a lot of excess volume that they're not going to need and they're probably not going to want. So keep that in mind, and like I said, we'll go through all these modes, and you'll see with patients' clinical presentations which one is better for which patient. So moving on, another mode to talk about is SIMV. With SIMV, you can set your rate, you can set the tidal volume, you set the PEEP. In addition to that, I have PS on there, which is pressure support. So as we talked about a minute ago, this is a mode where you have pressure support that helps augment the patient's respiratory drive and helps them compensate for the tube. So that's the whole reason why you get pressure support, is for the tube compensation. And that's why you get it in SIMV, because the patient is doing some spontaneous effort on their own. And why you don't get it in other modes, because of this being SIMV. So as I said, it allows the patient spontaneous breath, but the nice thing is that it's a spontaneous breath with a tidal volume that they want. So if you have a set tidal volume of 500, don't be surprised if you see on your ReVel ventilator that a measured spontaneous breath is only 180, 200, 250. So don't be surprised if you see that. And the reason you see that is because that's just what the patient wants. And that's the nice thing about SIMV, is it allows them to do that. So as I said, giving them the volume they want, it helps prevent breath stacking in your auto PEEP, which, as you remember, the auto PEEP is the incomplete exhalation. So that's some good benefits of SIMV. Patients you'll typically see SIMV in are post-op patients, a lot of heart patients you'll see, cardiac patients, and patients that are either sedated or non-sedated that have still some spontaneous drive intact. The next one we'll talk about here is PRVC, which is pressure regulated volume control. In this mode, you set the tidal volume, you set the rate, you set your PEEP. So PRVC is kind of known as a lung protection mode. And what I'll tell you about a lot of these different modes is some of them are kind of physician or hospital specific. And what I mean by that is that, sometimes it simply is physician preference. And, some of these modes are on a pretty even keel as far as really like PRVC and SIMV when you're talking about your quote-unquote stable patient. So what I'll tell you is that when I did my clinicals when I was in RT school a few moons back, I did a lot of clinicals at TGH, and I can tell you at TGH, they use a lot of what they call SIPs, which is SIMV with pressure support. However, what I can tell you in my years that I've worked at St. Joe's as an RT, what I can tell you is that we use a lot of PRVC there. So don't be surprised if, at different facilities you see different modes. Like I said, sometimes it just boils down to physician preference. But staying on track here with PRVC, it delivers your set tidal volume, but at a minimal peak inspiratory pressure. So the trick with this is, I'll say this first. So basically it helps to decrease your peak pressure by reducing the minimal amount of tidal volume for that peak pressure, and in that it helps reduce barotrauma. So patients you'll typically see this in, especially the biggest patient population basically is cardiac and post-op patients, and basically patients with normal compliance. And so basically the catch about PRVC is, say if you have your upper alarm limit set at 40. So once your peak pressure hits 35, the vent stops delivering volume because that's its mechanism. Like I said, it's a lung protection mode. So that's the mechanism in that mode to help prevent any kind of barotrauma in the lungs. So that's all fine and dandy, except if you have a tidal volume of 500 and you only have gotten 100 of those mLs of that 500 delivered, then that's still cutting you 400 short. So because of that, you're not going to be doing 4 to 8 liters a minute ventilation. So again, I go back to the point of emphasizing how important your peak inspiratory pressure is. Because if your peak inspiratory pressure and your alarms are very tight together, then you could very likely not be able to effectively ventilate your patient on this mode, because it's going to cut short and not deliver all of your set tidal volume. So that's one of the nuances about PRVC. So something just to keep in the back of your head. You can increase the upper limit alarm. The default on the ReVel for your upper limit is 40. So say if you increase that upper limit alarm to 50, and then once your patient hit their peak pressure of 35, you're still going to get their volume. But again, you just need to know what their peak pressure is and know what mode you're in, and maybe that's not a good mode to be in. So food for thought. Our next mode we'll talk about here is APRV. Like I said, it's typically where you're going to see it in a critical care environment, specifically, ICU, CCU. Another name for APRV is also called bivent, or it's also called inverse ratio. And the reason it's called inverse ratio is because you have a very long I time, which is your inspiratory time, and a very, very short E time. So like I said, these patients, their problem is oxygenation. And so that's why you have such a long I time, is for alveolar recruitment. And so that way the alveoli are inflated for a long period of time. So you may hear people talk about a P1 and a P2, and a T1 and a T2. And so what that is the P stands for pressure, the T stands for time. So what you have is the P1 and T1 correlate, and the P2 and the T2 correlate. So basically you have the time that you're at the P1, which is your high pressure, and then you have the time you're at P2, which is your low pressure. So basically common numbers you would see, just so you have some kind of an idea, is your P1 would be typically like 20, 25. Your P2 is going to be 0. Your T1 is going to be 5. So basically you're going to spend 5 seconds at a peak pressure of 25. And then your T2 is 0.3. So basically you're going to spend 0.3 seconds at 0. So basically that allows you, that 0.3 seconds allows you for your ventilation aspect, because it's such a short time frame. Like I said, you're spending a lot of time in the inspiratory phase, but even such a short phase of 0.3 still allows you to ventilate, believe it or not. So.
Have you guys transported anybody on this? Yeah. Typically these patients, they're asking for air transport.
Yeah.
On if they can't, for weather or whatever reason, then they'll usually delay the transport until, a critical care unit can come and transport them. They're usually pretty sick and unstable.
Yeah, absolutely. And like I said, patients you'll see this in typically are your ARDS patients, patients that are having oxygenation problems. And basically this is the mode you see when all of your other traditional modes have failed. So maybe they've done assist control, maybe they've done pressure control, they've done PRVC, SIMV, and all of that has failed. So these are the patients you would see that mode in. Basically, they would do probably APRV right before they went to an oscillator. So just to give you an idea of how sick we're talking about. So now we're talking about another mode, and on the the non-invasive side of the house. We're talking about CPAP, which I'm sure you guys are pretty familiar with. Obviously requires spontaneous effort by the patient. So with that, you're not setting a rate and you're not setting a tidal volume. Typically, the patients you're putting this on are patients with OSA, which is obstructive sleep apnea, which typically is more of a home setting that they use at home at night. Or you can see it in the hospital if they're admitted and maybe they have a CPAP at home, so they'll typically use a CPAP in the hospital at night as well. Other patients see this on is refractory hypoxemia patients, and then also your CHFers. The parameters as far as what you would normally set for CPAP or what you would normally see is typically they start out around the 5 to 7 range, and that's 5 to 7 centimeters of water is what your measurement is. And if you want to increase that, you increase it in increments of 3 to 5. So say if you start out at 5 and the patient's not getting the tidal volume they need, then you would typically try and bump it to like 8, and then maybe try and bump it to 10. I would say at that point, if you're still not where you need to be, then you need to talk or think about BiPAP. The complications of CPAP is, especially for patients that are new to CPAP, is the discomfort of it and the fact of the claustrophobia aspect of them having a mask over their face. A lot of patients really don't deal with that very well, and especially their first time, and they don't realize how much it's going to help them. But you really have to do some coaching and to get them kind of over that hump. Typically what I do is I hold the mask away from their face and gradually put it closer. And obviously you're not doing that over 10 minutes. I mean, you're doing it over a, like minute and a half time span. But, just putting it closer to their face until the point where it's, fairly snug, and maybe not tighten it down yet, but just hold it gently on their face, and then, work your way to it's tight enough so it's making a good seal. Because as you guys probably know, a good seal matters both for CPAP and BiPAP patients. If you lose that seal, then you're losing that positive pressure. A lot of it's leaking out and it's not working like it's supposed to. So, talking about how to titrate, we touched on this a second ago, but basically you're not probably going to have a way to measure their tidal volume. So what we're looking for is just going back to basics and doing it old school, which is you want to look at the patient's work of breathing, you want to look at their heart rate, you want to look at their LOC, their skin, their respiratory rate, and their O2 sats. So just assessment 101 with them. Moving on to BiPAP, as I said, if CPAP isn't cutting the mustard, then BiPAP's what you want to think of next. And the thing about BiPAP, as you guys probably know, is it's 2 levels of positive pressure. You have a inspiratory positive airway pressure and a expiratory positive airway pressure. This, just like CPAP, requires spontaneous effort by the patient, and typical parameters you're going to start at is either 10/5 or 12/5. You typically need a 5-point spread for this to be effective. And when I say a spread, I'm talking the difference between the EPAP and the IPAP. And so basically, if you want to get a bigger tidal volume, then you have a bigger spread. So instead of a 5-point spread, maybe you need a 7 or 10-point spread. So if you start out at 10/5 and their tidal volume is only like 150, and they need to be in like the 400 range. So when you start with an IPAP of 10, then bump your IPAP to like 12 or 15, but keep your EPAP at 5. So when you bump up your IPAP, you're now increasing that spread. So that spread is what augments the patient's tidal volume. So just keep that in mind, and that's relevant for pressure control that we'll talk about here in a few minutes also. Obviously, indications for this are patients with a spontaneous drive, but a subpar minute ventilation range and or a subpar oxygenation status. So we're going to talk about some parameters of ventilators, kind of what your settings are, a good jumping point for a lot of this stuff, and I hope this is helpful for you guys as well. As we talked already quite a bit about tidal volume, so 5 to 8 mLs per kg is what you're shooting for adults and peds. And that's 5 to 8 mLs per kg of ideal body weight. As I mentioned in the scenario earlier, or the case study earlier, that's why ideal body weight matters. So you're shooting for 5 to 8 mLs of ideal body weight. For infants, it's 4 to 6 mLs per kg. And then for ARDS patients, it's also 4 to 6 mLs per kg. And specifically for ARDS patients, you're doing low tidal volume, but a high respiratory rate and a high PEEP. Because as we know for the ARDS patients, their problem again is oxygenation. So that's why you want to do high PEEP and of course high FiO2. Moving on to PEEP, as I said, you start at 5, that's your intrinsic PEEP basically, and increase those in increments of 2 to 3. The caveat to PEEP, and you guys probably know this, is while you're doing that, just make sure you watch your blood pressure. Because the problem with PEEP, if you increase the PEEP, is that the more you increase it, the higher your PEEP is, the more intrathoracic pressure you have. And why that matters is the higher intrathoracic pressure you have, the less venous return you get. So the less venous return you get, the less cardiac output you get. And it in turn basically will dump your blood pressure if they're on a really high PEEP. So that should ring a bell, hint, hint, in one of the case studies we talk about. For your respiratory rate, like I said, a good jumping point. In this slide, I know it says 8 to 12, and that's what a lot of textbooks will say is a quote-unquote normal respiratory rate. But I'd like to throw this out for consideration that all of us in this room are in a transport environment, and I'm sure we could all agree that not many of our patients are breathing 8 to 12 times a minute. So, typically that's going to be a little bit higher just because there's so much stimulation, there's so much going on with a patient. So, most likely they're probably going to be in the 14 to 16 to 18 to 20, maybe even up to like 24 range that'll be quote unquote normal. So I know this says 8 to 12, and that's what textbooks will like to tell you, but I don't think textbooks take into account the transport environment. So just keep that in mind. Your peak pressures, we've talked about quite a bit already. You want that under 50. If you start knocking on 50, you should be concerned because there's something going on, like i.e. maybe a pneumo, or maybe you have a pretty significant obstruction. So, or the other thing most commonly with vents, if you get high peak pressures, especially if it's intermittent, is the patient's coughing. And maybe they're coughing so they're bucking against the vent. So that's going to trigger a high peak pressure. And obviously your solution for that, if that's the scenario, is think of some good sedation. So you can sedate them effectively so that, because it gets to the point sometimes where patients cough so much that you're now not ventilating them because the vent's shutting off, or it's not able to deliver volume because the patient's coughing against it. And so then you go back to your minute ventilation concern of 4 to 8 a minute, and if the ventilator's blowing up because of high peak pressure, then obviously you're not ventilating them, especially when they're coughing. So just think about that as far as effective sedation goes as well. Moving on to plat, which again is your plat pressure. That needs to be under 30. And again, if it's above 30, you really run a high risk of a pneumo. So just keep that in mind. And as we said, the way to get your plat pressure is by doing an inspiratory hold on your ReVel vent. So that can be something to know. But I'll tell you a quick trick is if your peak inspiratory pressure is say 25, then don't even worry about your plat pressure. Because if your peak pressure, which is a dynamic measurement, is 25, I promise you your plat pressure is going to be under that. Because a plat is a static measurement. So again, which is why it goes back to keeping an eye on your peak inspiratory pressure. And if it's under 30, then you're not going to have to worry a whole lot about your plat pressure. And typically on a normal compliance patient, the peak pressures you'll see, just to give you an idea, I've seen them as low as 8. I would say that the typical number I typically see is in the teens. So maybe 14, 18, maybe low 20s. So that's what I typically see the most when I'm at my RT job, and typically what I see the most on my patients that I transport at Aeromed. So just to give you an idea, so if a normal pressure, peak pressure is like 18, but then now all of a sudden you see a peak pressure of 54, that should throw up a bunch of red flags. So again, why it matters to watch your peak pressure. So moving on with IE ratio, as we said earlier on how to figure that, your typical IE ratio when your ReVel ventilator figures it out for you, it's one of the values that scrolls across the top of the screen. And it's that scrolling It'll, it tells you like your spontaneous respirations. It's basically all your measured parameters. So that's what you'll see on the top of your screen. Typical IE ratios is like 1 to 2, 1 to 3, 1 to 4, maybe 1 to 5, but typically either 1 to 2, 1 to 3, or 1 to 4 is typically what you guys are going to see. So I put a picture of this servo screen up here. This is the type of ventilator that we use at my RT job, and I realize that you guys aren't going to see this a lot, but the reason I put this picture up here is that after us talking about a lot of this stuff we've been talking about to this point, these numbers should mean something to you. And what I'll tell you real quick is all these numbers across the bottom right here, those are your set parameters. And all these numbers on this far right column, those are your measured parameters. So as you see right there, 20, that's your peak pressure. The next number down, the big one in the green, is respiratory rate of 14. And then your FiO2 measured, it's being delivered, is 60. The 7.5 is your minute ventilation. So are they in a good spot right now at 7.5? Yeah, because they're in the 4 to 8 window, so they're good. And the other reason I took this picture is this was on an actual patient. So that way you can see actual numbers on a live patient and not hooked up to a mannequin or lungs or whatever. The other thing I'll tell you real quick is you see this set rate here of 14, and you see over here the measured rate of 14. So when you walk into a hospital and you look at those two numbers, if you happen to be doing an interfacility transport, the quick down and dirty is you can tell right there, right out of the gate, that the patient's not breathing over the vent, because their set rate is 14 and their measured rate is 14. So that comes into play when you're thinking about what modes you want to put the patient on. Because this patient either doesn't have any spontaneous respiratory drive of their own, or maybe they're paralyzed, or maybe they're very well sedated. So I won't spend a whole lot of time on this, but just so you guys kind of know, this is a real deal and those are real numbers. So moving on to some troubleshooting with the ReVel ventilator, specifically things you could come across, as I mentioned again about your peak pressure. So for your high peak pressure alarms, what I want you guys to think is obstruction. And for your low peak pressure alarms, what I want you to think about is a leak. So think low leak and high obstruction. So these are for your high peak pressure alarms. Like I said, these are good examples of obstructions. So I'll list these in actions because these are things you can do to help mitigate that alarm. First thing I would do is check your ET tube. A lot of times, and I've found that some of these ET tubes, maybe the plastic's made in China, I don't know, but a lot of times ET tubes like to fold over. And it seemed like back in the day, years ago, the plastic was thicker on the ET tubes, and they didn't tend to do that a lot. But I just see more and more often that they're doing that. And so if that ET tube is folded over, then there's your kink. And that could be very likely the reason why you're getting a high peak pressure. The next thing I would check would be your circuit on the ventilator. Your circuit going from the vent to your ET tube, that could be kinked. And we all know in this scenario, when you have a patient that's intubated, like we talked about right before the lecture, there's a lot going on. And so there's probably a lot of people in the back of that box with you. And maybe somebody's stepping on the circuit. Very likely scenario. And not that anybody's doing any of this stuff on purpose, but it just happens. So just keep that in mind. Another action to take is to suction. Maybe the patient has, they're coughing or they were coughing and they have a lot of mucus in their ET tube. So that mucus could be causing an obstruction. And last but not least is to do lavage. So that little side port on your ET tube, you can, the little cap, you can unplug, take that cap off, and get one of those little saline bullets or get a saline flush and squirt it down that line. And the reason you do that is basically if there's a potential mucus plug. So that way that lavage will break it loose and then you can suction it. If it's small enough, if the mucus plug is big enough, then obviously it's probably not going to pass through. You're not going to be able to suction it through your ET tube. But that's all right. That's all right. But at least with lavaging, you'll be able to push it away from the base of the ET tube. So just know that could be a very real scenario. And I just had actually about probably 2 weeks ago on one of my RT shifts, had a trach patient that was coughing up or trying to cough up a huge mucus plug. So once that clears, it's like night and day, like giving a patient some D50. It's a night and day change. Once they clear that mucus plug, then now that airway is now patent again. So if you ever have dealt with a mucus plug, then you'll never forget it, and you'll know how big of a difference it is with the patient once you clear it. So I know we don't lavage a lot, but I just want to make sure and mention that as something to consider that could very likely be the scenario. So just don't forget about lavaging. So moving on to low peak pressures, again, I want you guys to think a leak. And why would you have a leak? Well, things you can do to check for that is, again, check your ET tube or the pilot balloon. Sometimes when people are intubating patients, and if a patient has sharp teeth, as they're passing the tube in, maybe one of their teeth catches the pilot balloon. And you don't realize it at the time, but after you pass the tube, you're in the cord, you inflate the cuff. Well, then now you're losing volumes, and you don't know why. And you're losing volumes because now that cuff is deflated or is not as inflated as it was because there's a leak in the cuff. You'll see that on the vent. It'll say a low volume alarm. So just think that might be a possible option. Obviously, the fix for that would be just to put down a bougie and pull that tube, throw a new one down, and reinflate that cuff on the new tube. So we talked about the pilot balloon, the ET tube. The other big thing is to check for the circuit. Like I said, the circuit could have come unplugged, or either from the ET tube end or from the ventilator end. So again, there's typically a lot of things going on with these patients. So just check all of that, and that's a good place to start. Or I guess another one to throw in there is a patient maybe is extubated. So, and obviously the big key for that is if you hear a rush of air coming out of their oral pharynx that you didn't hear before. Or heaven forbid, I've had this happen where somebody caught something and pulled the tube and you didn't see it. And then next thing you know, you look down and you can see right at the end of their tongue is you see the pilot balloon. You're like, well, great. Obviously, that tube's not in anymore. So anyway, so moving on to, as we said very early in this lecture, the two things you're wanting to do for ventilators is you're wanting to ventilate them and oxygenate them. And the indicator of how well you're ventilating them is your CO2. So I'm sure that you guys use Entitle on your monitors. And of course, so that's the way, obviously, that you monitor your CO2. So to talk about a couple of things about how to optimize your CO2. If your CO2 is high, so in other words, something above 45, because you're shooting for an Entitle of 35 to 45. So if your CO2 is, say, 55, then we know that's high. So the action you should think of is, number one, increasing the tidal volume, or B, increasing the rate. That being said, I want to encourage you guys to increase your tidal volume first. You'll get more bang for your buck if you increase the tidal volume first. That being said, make sure that your tidal volume is within the 5 to 8 mLs per kg. So obviously, if you're exceeding the 8 mLs per kg, then increasing your tidal volume first isn't the right choice. But and the other thing to think of is if you happen to have gotten a plat pressure and you're knocking on 30, increasing your tidal volume is going to put you closer to 30 because of it contributing to your peak pressure measurements. So just keep that in mind, but ideally if everything's within range, increase your tidal volume first before you increase your rate. With the low CO2, you want to do the opposite. So if your CO2 is measuring, say 20 on your end tidal, then what you want to do is decrease your tidal volume so that your CO2 comes up. Or you can decrease your rate so that your CO2 comes up. So it's kind of an inverse ratio. Basically between the relationship between end tidal and your tidal volume. It's an opposite relationship. So obviously, if you have your end tidal on this side and your tidal volume on this side, kind of picture again your seesaw. So if your end tidal is going up, then your end tidal, if your end tidal is going up, then your tidal volume is low. So just think of it as a seesaw, and that's your fix for it. Like I said, just keep in mind if you increase your tidal volume, keep in mind about your plat pressure, and as I mentioned, doing your tidal volume first. So the tool for oxygenation, as we all probably know, your two tools in the toolbox is PEEP and FiO2. So just quickly, we talked about PEEP starting at 5, and obviously your FiO2, goes all the way up to 100. So just when you raise your PEEP, just again keep in mind, keep an eye on your blood pressure. So on to ABGs real quick. These are your quote-unquote normals. Your normal pH is 7.35 to 7.45. Even though that's a pretty tight window, your body does an incredible job of staying within that window in a normal, healthy state. Your CO2, easy way to remember that is just drop to 7 of your pH. And then you're at 35 to 45. Your normal PO2 is 80 to 100. And your normal bicarb is 22 to 26. So with that in the back of your head, we'll go on to how you do a quick ABG analysis. So it's really 3 easy steps that you want to look at. Number 1, you want to look at your pH. You want to see if it's normal, if it's acidotic or it's alkalotic. Secondly, you want to look at your CO2 and ask yourself what that value is, and that'll tell you if the patient's ventilating or not. And then thirdly, look at the PO2 and to tell you if the patient's oxygenating or not. So when you're looking at the ABG, this system is very easy, it's very methodical, and you can use it every single time and it works. So the name of this system to interpret ABGs quickly is called ROME. So what ROME stands for, or the ROME method. So what ROME stands for is respiratory opposite, metabolic equal. So with that in mind, what to know is that for your respiratory system, your buffer is your CO2. In your metabolic system, your buffer is bicarb. Now just know that out of those two, your respiratory buffer happens a lot faster than your metabolic buffer does. So when you're looking at your ABG, you want to look at like I said, you want to look at the pH and you want to look at your CO2 and your bicarb. So when you look at it, looking at your pH, look at your CO2 to see if it's a respiratory problem, and look at your pH and your bicarb to see if it's a metabolic problem. So basically what that means is respiratory opposite, metabolic equal. So if it's a respiratory problem, the two respiratory components are going to be going in opposite directions. In other words, your pH could be going down. Expect your CO2 to go up. So that's where you get your opposite. And that's why you need to understand which things you're looking at. So when you look at, again, if you're looking for a respiratory problem, you're looking at pH and CO2. That can go either way. You might have a pH that's high and a CO2 that's very low. But the takeaway from that is just know that if it's a respiratory problem, those two components are going to be going in opposite directions. Now, if it's a metabolic problem, you're going to be looking at your pH and your bicarb. So in that scenario, metabolic equal, what that means is that your pH and your bicarb are going in the same direction. So they could both be trending up or they could both be trending down. But the thing to know and the takeaway is that they're going in the same direction. So just for some quick examples, like if you had a pH of 7.25, and we'll say so in this scenario right here, you see number one, that this is acidotic because it's below 7.35. So then you look at your CO2 and you see it's 62. You're thinking, so that's a little high. So then you look at your bicarb and it's 24. Well, you know, that's in normal because bicarb range is 22 to 26. So in this scenario, that's your red flag. So number one, you know that it's acidotic. So, and you know it's a respiratory problem because they're moving, the pH is low, the CO2 is high. So you're moving in opposite directions. So there's your answer. And I heard somebody saying it, so strong work. So respiratory acidosis is your interpretation. So we'll do just one more example. Let's say so, again, step one, look at your pH. So you know that's above 7.45. So we say that's alkalotic. Oof. It's a terrible K. And then we look at our CO2, 35 to 45, so that's good, right? So here's bicarb at 32. So that should be your red flag because, again, bicarb is 22 to 26. So you have your pH going in the same direction. You have your bicarb going in the same direction. So it's a metabolic problem. So metabolic alkalosis is your answer for that one. So in a nutshell, that's using this ROAM system. Works every time, very systematic. Look at the pH, look at the CO2, look at the bicarb. So I hope that doesn't confuse people. And if you want more discussion after the lecture, I'll be happy to do it. I'm just trying to keep it simple, and that way you guys get a good idea of how to put that together. So some pointers on the ReVel. This is probably the biggest one I'll tell you is if you're using BiPAP, a lot of times what it'll tell you on the screen is that it's 7/5 is the values. But I want to make sure that everybody in this room knows that what the ReVel vent does is it takes the pressure support and adds it. So what that means is that it's a pressure support of 7, that it's adding to your PEEP of 5. So what that really means is your IPAP is 12 and your EPAP is 5. So why that matters is because if you guys have a patient on CPAP and you're giving a report somewhere and you tell them that they're on 7/5, that might throw up a red flag because they're going to wonder, number one, well, that's only a 2-point spread. So how are they getting good tidal volume with only a 2-point spread? The real answer is it's not a 2-point spread. They're really on 12/5. So that's why I mentioned that so that you guys know when you're giving a report, just to know what the actual is. And when we go through the ReVel, you'll see that. But just know that the ReVel does that. Secondly, if you have an alarm message that says blower alarm, that typically is one of two things. It's either a leak or the patient is pulling more volume than that vent can deliver. I'll give you a great example. A DKA patient that's on BiPAP, and I'm not sure how many of you guys in the room have had experience with DKA patients, but I will tell you, they pull mad, crazy tidal volume. Not only mad, crazy tidal volume, but they're also very, very tachypnic. And the reason they're doing that is because their metabolic state. That's the body's natural compensatory mechanism, and it's trying to blow off all this CO2. So the reason I tell you that is because if you happen to do an interfacility on a DKA patient, don't be surprised when you see their vent settings that they have a really high respiratory rate. And what I want to emphasize with that is match the rate that they got at the hospital, because you need to make sure that they get the same minute ventilation, because they need that same minute ventilation to keep blowing off that CO2. And so you know, or just also know that even though you might have a high respiratory rate and a high minute ventilation, you still might be getting high end-tidal readings on your monitor. And just know that that's something you're not going to be able to fix in your 20 or 30 minute transport, because it's a metabolic problem that you're not going to fix in 20 minutes. So
if you adjust their rate down because you don't think that it's appropriate, you could make the situation worse during that 20 to 30 minutes of
Yeah.
transport time for sure.
excellent point. And specifically, you're going to probably make them very acidotic, because they're going to be retaining all the CO2 because they can't blow it off because they don't have an adequate minute ventilation. So again, you know, your normal minute ventilation is 4 to 8, but just expect for DKA patients that you're probably going to easily exceed 8 liters a minute. And I'll give you a factual case of a few years back. I flew a DKA patient, same deal. He was on BiPAP, and he was pulling 9 to 1,200 mLs of tidal volume. And he was doing that every single breath, and he was doing that 38 to 40 times a minute. So do the math, and that is some mad, crazy minute ventilation. And again, it's just because he was a DKA patient. So just expect that and know that that can be a likely scenario, and just know how important it is to match their current minute ventilation. So moving on, another pointer to tell you about the ReVel ventilator is in the SIMV mode. We mentioned about pressure support. You'll see on one of the screens on the ReVel, it defaults to 10. And on any other mode, that pressure support screen isn't lit up, but in the pressure support mode it is. Or excuse me, in the SIMV mode it is. And the reason it is because, again, in SIMV, the patient's doing some spontaneous respirations, so that's why the pressure support matters. So you're augmenting their spontaneous effort. So just know that that pressure support is 10. The other thing I'll tell you about the ReVel ventilators is the alarm limits. The defaults, I think, obviously they didn't consult me when they were doing this vent, but I think that they, specifically their low default of 10, I think is really, really high for a low alarm. And I'll tell you, because again, I've had patients that their peak pressure is 8. So if you have a low alarm at 10, that thing is going to be blowing up as soon as you put it on them. So the other thing I'll tell you is their high alarm default on the ReVel is 40. And I think 40 is kind of low. And I say that's kind of low, again, in the context of a transport environment. If you have a patient that's been chilling out in ICU for 3 weeks and they're sedated or paralyzed, then obviously 40 is pretty appropriate. But in a transport environment where you're stimulating these patients, maybe you hadn't had a chance to sedate them yet, or maybe you've given them sedation, and the sedation you've given them isn't enough, and you got to give more. So, there's a lot of stimulation with moving them. There's stimulation with you tubing them. So there's a lot going on. So I typically, basically, at the end of the day, to cut through the chase, I put my low alarm to 3, and I put the high alarm to 50. And I'll tell you, ever since I started doing that, it's like magic. You know, it's like there's been that alarm, or the vent has not alarmed near as much as it used to. So those are things that have really helped me. I will caution you that I wouldn't put the low any lower than 3, because you want some kind of warning if something's going south, especially if the vent circuit comes unhooked, or if the ET tube comes dislodged or unhooked from the circuit. You want some warning. I had somebody tell me, they're like, oh, well, always put it to 0. I'm like, oh, no, don't do that. Because if you put it to 0, you have no alarm when something goes south. You have no warning when something goes south. So with 3, it's still enough of a warning that it gives you time to fix the problem. So food for thought. So some disease considerations with specific patient populations and how it relates to the ventilator. One good example is asthma and COPD patients. And what I would tell you is to consider extending the E time, so your exhalation time, so that they get a more complete exhalation time so that you reduce air trapping. And how you do that on the ReVel is, and we'll go through it, but you have an I time set on there. So basically, if you reduce the I time, you're going to increase your E time. So it's just a simple matter of on the ReVel, the default is 1.0, so 1. Just like when we figured total cycle time and your IE ratio and all that, your normal default for inspiration time is 1 second. So if you turn that down to like 0.7, now you have a longer E time. So that's how you expand your E time on the ReVel. And also DKA patients, which we talked about, just again emphasizing understanding their metabolic state and that they're producing a lot of CO2 and their body's doing its best to blow it off and get rid of it. So, all right, so back to case study number 1, and hopefully this will put all of this together for you guys. So this is the first one we talked about at the start of the lecture. 68-year-old male, 80 kilos, intubated at 8 at 23. He's sedated, has a GCS of 3, and well ventilated. So the current settings are SIMV, a rate of 10, volume of 550, 100%, and plus 15 for PEEP. And there you see your vitals of 62, 84/60, measured respiratory rate of 10, and SAT of 98%. So that being said, coupled with stuff we talked about before now, what are some things that jump out at you guys in that scenario? Exactly. And besides the high PEEP, look at that. Right. So they've got a ridiculous amount of high PEEP and they're hypotensive. So what that tells me is that that PEEP is too high because they're sat 98%, and it's so high that they're hypovolemic. And so, you know, you can guess that they probably have some pretty significant intrathoracic pressure because of the high PEEP. And I'll give you an actual, I don't want to swap war stories all day, but I'll tell you an actual relevant story that happened. Years ago, I was doing an interfacility transport, went to unnamed hospital, picked the patient up, we're getting report, and the patient's on 15 a PEEP. And I asked the nurse, I'm like, wow, well, that's kind of a lot of PEEP. I said, are they having an oxygenation issue? And the nurse says, well, I don't know. I said, okay. I said, well, have you guys done a recent ABG? And she says, well, I don't know, I'll have to check. She goes, I'll tell you what, do you want me to get the RT? I said, fabulous, yes, please. So she gets the RT comes, same discussion. I'm like, it's kind of a lot of PEEP. She's like, yeah. I said, well, are they having an oxygenation issue? She's like, well, I don't really know. I said, okay. She goes, well, do you want me to get my charge therapist for you? I said, perfect. So she gets the charge therapist. Charge therapist comes in, same conversation. And she goes, well, you know, I don't really know why they're on that much PEEP. The doc just said just to put them on 15 and walked out. So, you know, here's somebody that doesn't know the, you know, parameters, doesn't know, you know, your jumping points of where to start. So Kelly's first action was to dump that down to like 8. and see how they did. And when I did, shocker, their blood pressure came up. So just know that can be a scenario for you guys, you know. You can go in to do an interfacility and, you know, I'm not saying ER docs are dumb by any means. What I'm saying is that, you know, sometimes poor setting choices are made. And they think they're doing the right thing, whoever they is, whether it's the RT, the doc, whoever, or maybe they did that on accident, who knows. But bottom line is, it's your job as a clinician to make sure that you do no harm to your patient and that you ideally get them to their destination better than how you found them. You know, so just know that things like that happen.
Well, and doing exactly what you did and making sure that you have those discussions with all of those persons to make
Yeah.
sure that there wasn't an underlying oxygenation issue. Because on the flip side, if you just came in and you're like, oh, that's plus 15, that's way too much, their blood pressure's a little low, let me turn that down. But there had been a prior issue, then you've lost some of that recruitment
Right.
as well.
Absolutely. So in that scenario, if there was an oxygenation issue, then obviously the next thing you'd want to do is try and adjust that blood pressure. You know, whether you want to give them fluids, obviously give them fluids, and maybe go down the road of pressors. So just know that's something to consider and something to look out for. So as we said, the interventions, decreasing the PEEP, getting a reliable history, and asking for a recent ABG to see what the PO2 was. And again, that'll answer your question if they've got any oxygenation issues. So, on to number 2, 38-year-old female, again 65 kilos, and intubated with a 7.5 at 21. She's alert, supine, restless. Your peak pressure and respiratory alarms are blowing up on your ReVel. And the current mode they're in is SIMV PRVC. Their set rate is 24. Tidal volume set is 750. 60% FiO2 and plus 5. You see your vitals there at 60, 102. Their total respiratory rate, the measured, is 42, and they're sat 98%. And you also notice their peak pressure is 54. So there should be a bunch of things that jump out at you in that scenario. So what do you guys think? Exactly. So yep, her set rate's 24 and her measured rate's 42. So on that note right there, what would you say would not be a good mode for her to be in?
One that keeps delivering the volume.
Absolutely. Assist control. Exactly right. Because they're breathing so much over the vent that they're going to have a lot of air trapping, because every time they breathe more than 24 times a minute and they're breathing 42, they're getting a tidal volume of 750, which is a lot. So just know again how that ventilator modes and picking the right one based on the patient's clinical presentation. This is a great example of how that matters. So excellent though, good catch. So that's one thing wrong. What else do you guys see wrong in the scenario?
The peak pressure was about 50.
Absolutely, good catch. So peak pressure of 54, that's in the zone you don't want to be in. You're over 50, as you said.
That's because she was 5'2", right?
Most likely, yeah, because she's restless, and with her being restless, and I get that this is black and white, you don't have a patient in front of you, but I would say that's a very likely scenario, is they're coughing and bucking the vent because they're restless, so that tells you that they need to be sedated. And try that. I would tell you another thing too along the same lines. I picked up patient after patient that's had some kind of traumatic injury, or maybe this is another great one, a patient that has a head bleed. You would be amazed how many facilities that have patients with head bleeds that have not given them anything for pain. I just had one my last shift, and it's happened all the time. And so my point is, when you have somebody that's restless like that and say this is a head bleed patient, ask if, again, going back to a reliable patient history, ask them if they've had any sedation, because that might be your problem right there, just sedating them. And you know, years ago at Aeromed specifically, we tended to paralyze a lot of patients. obviously we would sedate them as well, but we tended to paralyze them. Well, that shifted, and our shift now is to emphasize more sedation and less paralytics. So my point of that is that sedation works, and sometimes it may take some tweaking for you to get to the right amount of sedation, but just know that that's a very viable option. So it may be in this scenario that they just need sedation, and you're going to solve this restlessness problem, you're going to solve this tachypnic problem, and you're going to solve that peak pressure problem. So, you're getting a lot of bang for your buck with just trying to sedate them.
Why would her tidal volume be so, I mean, why would the volume they're putting in be so high?
Excellent.
That's an 11. It's 12.
You are 100% right. So absolutely, that's another point in this scenario, is that needs to be fixed. They're way outside of their 5 to 8 range. And when we talked earlier in the lecture about how tidal volume can contribute to peak pressure, here's a great example of that. So I bet you if you sedate this patient and you drop their tidal volume back to a 5 to 8 range, you're going to have an enormous impact on that number right there. So excellent, great catch. So we'll go to the interventions, and here we go. So number 1, sedate the patient. Number 2, we just talked about the tidal volume. That's your range for that patient for their kilogram 5 to 8 range. And you can see even at 520, at the high end, at the 8 mLs per kg, even at 520, them being at 750, that's way outside the range. So another option is you can decrease your respiratory rate, because their rate, I believe, was 24. So it's another option. And then last but not least, maybe suction ET tube. Because as you said, which great point and very possible, is maybe they're coughing and they're bucking the vent. So if they're coughing, they got a lot of secretions in the ET tube, so suction the ET tube out. And that should get you well on your way to fixing that problem.
Is it
Yes.
possible they have, like, the rate is up that high and the volume's up that high, as we talked about DKA? Is it like trying to compensate for DKA that they would just put those settings?
Could be. However, what I would say is if they're a DKA, they're probably not going to have that high peak pressure. But not a bad thought. So I would say minus, I'm sorry?
You sedate her and see if the peak.
It's best to just give us that reliable history also.
Yeah.
Make sure you try to get as much information as you can before you make those adjustments, so that you are trying to find out, all those little clues that might indicate why they have the settings that way before you make your adjustments. And, don't make all the adjustments at one time.
Yeah. Exactly. No, great point. Right, exactly, great point. And that's what I was going to say. I already took the words out of my mouth, was that when you do make changes, don't do it all at once, because sometimes it's a matter of just changing 1 or 2 things. And if you're changing 2 things and you do them both at the same time, you don't know which change worked. So I would also say, and I read charts sometimes or talk to people, and they're making vent changes every 3 minutes, and it's like a 20-minute flight, and they've made like 5 vent changes. I'm like, listen, man, it's like, so slow down a little bit and just understand that to be conservative, but also to try and get a reliable patient history and understand what the real problem is. And just like reading blood gases, look at the blood gas and understand what the problem is. If it's an oxygenation problem, is it a ventilation problem? So, your ventilation problems you're going to fix with tidal volume and rate. Your oxygenation problems you're going to fix with PEEP and FiO2. So like any scenario, just understand what the problem is first, so you know what the fix is. If you don't identify the problem, then you're probably not going to identify the right fix. And just, like I said, 1 at a time, so you can work your way through it. So the takeaways from this lecture, if you guys don't get anything else out of this, what I want you to walk out of this room knowing is how important it is to monitor your peak inspiratory pressures. And again, your ReVel will tell you that, and we'll show you that on the ReVel on that top scrolling screen. And then also to monitor and trend your end tidal, because your end tidal will tell you a lot. If you have an end tidal and the patient's been running at, say, 38 to 40, and all of a sudden now you got an end tidal of 8, you got a problem. And I would say the first thing you should do is do a pulse check, because it could very likely be that they're coding. You know, obviously, as everybody in this room knows, you know, you could still have a nice, pretty complex on the monitor, and guess what? They're in PEA. So if you look at their end tidal, then if you have a significant drop like that, and basically the kind of rule of thumb is if it's 10 or less, you got problems. And the patient's got problems, and they're probably dead. They're just not dead yet. They're not officially dead. But that's why it's really important to monitor your end tidal. So I would say out of any of this, those are the two biggest things. Monitor your peak pressure and monitor your end tidal. And I'll tell you a lot about how well your patient's perfusing, how well they're oxygenating, and how well they're ventilating.